You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. Kennedy, well, I mean, John, I still feels a little strange saying that, but I'll go ahead and say it now. Welcome to the podcast.
Thanks, Cody. Great to be here.
Yeah, and today we're going to talk a little bit about some osteochondral lesions of the talus. But before we get into that, we kind of ask our guests just a couple of questions, just getting to know them a little bit better. And you have a little bit more interesting of a background than, not to say our other guests don't, but you have a little bit more interesting of a background. You can kind of just let us know a little bit about kind of where you're from and how you got to where you are now, because now I actually work with you and you're part of my fellowship.
Well, I'm originally from Dublin in Ireland. I graduated from the Royal College of Surgeons Medical School, and I did my basic surgical training. We do general surgery first, then we do orthopedics. I did most of that in Ireland. I did a couple of fellowships then in Boston, went back to Ireland and realized that I needed to get back to America quickly. And so then I came over to America, or to New York rather, in about 2000. And I've been here ever since, trying to make enough money for my airfare home.
You got to do what you got to do.
Got to be done.
And so I guess when you moved here, what brought you, I guess, more towards the academic side of things? Because you're one of my mentors and teachers now that I learned from. And what brought you more towards that side?
So look, I think one of the things in Ireland that we're very good at is the clinical aspect of things. But in any predominantly socialized healthcare system, there just isn't the funding for innovation and research that you'd have in America. And while the world may all be complaining about America, and we may even do it ourselves sometimes, there is no better country than America, particularly when it comes to medicine. And for me, back in the late 1990s and early 2000s, this was the pinnacle of innovation. And I knew that's really what I wanted to do. I didn't want to be doing what everyone else was doing necessarily, even though they were very good at it. I wanted to see if we could improve. And so there's no better place, as I said, to come than the American healthcare system. And I've been very, very fortunate. I've had some terrific mentors. I've worked with some great people. And any small success I've had has been in large part due to those mentors and all the people on the team. There's a great, in the places that I've worked in America, there's been a terrific team spirit to get things done. That includes not just on the clinical side, admin side, but also in industry. I think there's a great collaborative spirit between industry and orthopedics and orthopedic surgeons who are interested in research.
Yeah, we're kind of learning, at least people in my stage, fellows and residents, we're kind of learning the dynamic between, or the relationship between, industry and surgeons, how you kind of work together. And I know you've done some of that in your time here, but kind of switching gears a little bit. We know right now you kind of do more of a sportsy foot and ankle practice that you have here, and so what brought you towards that? What's the story that made you say this is kind of the things I want to do?
Well, I suppose I'm a disaffected sports surgeon. I was trained predominantly initially in sports, and that's where my passion was. And again, as I said, I was fortunate to meet some really great mentors. Russ Warren at Hospital of Special Surgery, one of those. And there weren't many people doing sports foot and ankle at the time. And he offered me the job there to do sports foot and ankle predominantly. And we'd Bill Hamilton, we'd Don Baxter, we'd a number of people around the country who were doing it, but nobody was really spearheading a lot of new innovation in that area. So to me, that was an enormous opportunity. Just to put it out there, I'm not a big fan of toes, so I like to say I'm more of a sports ankle guy.
Right. And switching gears, today we're going to talk about osteochondral lesions of the talus. And almost, if you Google this, your name pops up. So you know you're well versed in this. So it's kind of giving just a little bit of background. What kind of patient was, or what's the patient, I guess you could say, profile that comes to your clinic that has these osteochondral lesions of the talus? Like, who do you see this in?
You see it in all ages, and it's and I think that's where we kind of we'll get into the weeds a little bit of this later on, but for years it was called osteochondritis dissecans, or OCD, but that was predominantly an inflammatory disease, not a traumatic disease. So most of what I see is a traumatic OCL. And if you think of the ankle, most of these occur in the talus, but less than 10% of them occur in the tibia. But it's where the cartilage is involved, the subchondral plate and the subchondral bone, and those three things are known as the osteochondral unit. And so the sort of patients that I see are typically athletes who've had multiple ankle sprains or an ankle fracture. Of course, cartilage being aneural, they don't even know that they've damaged the cartilage at the time. And it's like a divot on the golf course. You just knock a little piece of it out and off you go. And over time, of course, that can progress into something more problematic in terms of hydrostatic pressure pushing in fluid into the underlying subchondral bone, and that's really what causes them pain. And the other group, the smaller group, would be more sort of in those patients whose growth plates haven't fused, and by and large, their cartilage is relatively normal. That's the OCD, or osteochondritis dissecans. That's predominantly a problem of the subchondral plate or subchondral bone. And ultimately, of course, it can become a problem with cartilage if the underlying structure isn't there. But they're treated differently, although the symptoms come on in roughly the same way. And it's usually somebody who's had, as I said, multiple recurrent ankle sprains, comes in not resolving, even though they're somewhat stable in terms of mechanical stability, just non-resolving pain, dull aching pain. And, we do, the first thing we do always is an X-ray. But of course, we know that only about half of the X-rays that we do will show us a definitive osteochondral lesion. So then we move on to more sophisticated imaging like MRI or CT to give us the diagnosis. Most of the patients that I see, because we're a tertiary referral center, have had conservative treatment elsewhere. And roughly around 40 to 50% of patients will respond in some way, particularly the younger people will respond in some way to non-operative treatment. And of course, by the time they get to me, we have to consider various treatment strategies. And as I'm chatting here, and I'm looking at your screen and you're going through all of the things that here, and I'll just sort of underline it again, about 50% of patients will fail with conservative treatment. I think we have to be a little bit careful of that figure now. It's probably less than 50% will fail, because we have all sorts of other things that we can use. And if you think this is a problem of cartilage and bone, well, we know that cartilage is unlikely to heal itself, but using biologics, and we'll probably talk about this later, I think, in your podcast, but using biologics, there is some evidence that using platelet-rich plasma injected into the joint, that will reduce the inflammation, turn off the catabolic process that is going on, and it certainly will be chondroprotective, but it may be chondrogenic and not necessarily true cartilage, but sort of more fibrogenic. It may produce a fibrous grout in the bony defect or the bony cartilaginous defect, which may provide some temporary clinical relief. So I think there's a whole host of biologics we can talk about that we use both independently and of course in conjunction with surgery. But that's typically the sort of patient that come in, they've seen other people, they've had multiple sprains, they're not getting better, and then we have to make a determination as to what we do with them.
Now, say for example, you just mentioned, the patient that comes in, again, a history of multiple strains, history of maybe an ankle fracture. So say for example, you have one of your research fellows goes in and sees one of the patients beforehand. What are some of the things that they should note on a physical exam? What are the things that you definitely want to hear from? Because we have a lot of, second year intern residents that listen to this podcast are just trying to figure out what exactly are the things that they need to pay attention to when they're going to see these patients in the clinic. So what are some of those things that you definitely want to know about?
This is why I love doing this podcast, because you're giving me hints here all the time. I just see it flashing up there. So let me tell you, they'll have ankle pain, possibly catching or locking, and occasional fusion on the background of a cavus hindfoot. But all of these things are true. And of course, it depends whether they come in with an acute injury or with more of a chronic injury, which is typically what we see. So you're absolutely right. They will have this history of pain, locking, particularly if it's an unstable OCL. giving way if it's floating around in the joint. They'll have an effusion by contrast to the contralateral side. Oftentimes they will have an anterior drawer, which will be positive. They'll have a varus tilt test. And all of those indicative of mechanical instability. Some of them will even have functional instability where you do a one-legged, almost like a Romberg test, and you see whether the proprioception is intact. And then limited motion as the body tries to protect itself over time. I think they develop a lot of cicatrization and scar tissue anteriorly. So a lot of them will have anteromedial and anterolateral impingement in conjunction with an osteochondral lesion. So I think your bullet points here are the most common things to look for. So, there's no such thing. Gino Kirchhoff's a great colleague from Amsterdam, always says there's no such thing as a simple ankle sprain. Probably 75% of the time in work done by Di Giovanni, they've shown that there's actually in a severe or grade 3 or grade 4 sprain, there is some form of either chondral injury or perineal instability or some form of chronicity to it. So I think when somebody comes in, multiple ankle sprains or an ankle sprain that's not healing, we are obligated to look to see what is going on within the joint.
Yeah, and you mentioned a little bit earlier that you would get X-rays, but a lot of sometimes the X-rays are negative, and you mentioned getting advanced imaging. How do you decide if you're getting between a CT scan or an MRI? When you have these patients, is there something that leads you towards one or another?
Again, as I said, we're really, really lucky in America because we can order MRIs, or we were able to until recently without any difficulty. Insurance companies were very happy for us to do MRIs. That's becoming a little bit more challenging. It's not that way in Europe where CT scan is preferred. So for our purposes, and I think for the purpose of those that are listening here in America, our algorithm is obviously we've got to do an ankle X-ray. Most patients will have an ankle X-ray anyway by the time they get to us for unresolving pain. As I said, only 50%, Loomer showing only about 50% of those will show up on X-ray. Then we go for MRI. And the reason we go for MRI is to go back to the nomenclature. This is an osteochondral lesion. CT scan doesn't show very well or at all, really, to my belief. It doesn't show the cartilage aspect of this, but of course it shows the bony aspect very well. So we do an MRI. MRI, I think, gives us a very good idea of the cartilage defect. Some nice, elegant work done by our previous fellows, and this is lots of pressure on you, Coach, to come up. It just shows, that the MRI oftentimes overestimates the amount of subchondral bone damage, and oftentimes you see these tali that are lighting up like a Christmas tree, in part because of the edema, this massive subchondral edema that's been pushed in there. But it does give you an idea of the activity of the lesion, and it does give us an idea of the subchondral plate. And I'll get onto the importance of that in a minute when we talk about microfracture and so forth. But again, it's to get back to the idea that there's really 3 critical components. There's the cartilage, subchondral plate, and subchondral bone. So I think for the purpose of MRI, it shows you the cartilage very well. It shows that the subchondral plate, it shows that very well in terms of the qualitative and quantitative aspects of that. And it probably overestimates the amount of bony damage. And that's when you have a very nice picture here on the right showing a cystic lesion. And of course, this is if we were to look at this in MRI, we wouldn't necessarily see that there was a giant bone void there. This would probably just look like a massive signal. The bone void is important because that needs to be grafted. We can't just do something on the surface of that. We need to do something more substantial to that. And this is what the criteria in terms of the volumetric size that points us down typical treatment guidelines. So in answer to your question in that long bloviating way that I've gone on to, is that most people will have a standard X-ray. Then here in America, we do an MRI, knowing that it may often overemphasize the size of the bony component. And if we have the luxury of doing a CT, we can do that also.
And so, we mentioned the non-op treatment. You mentioned a little bit earlier, and you said not all the way 50%, but less than probably 50%. will fail conservative treatment. And quickly, what is that? Are you just again? They're just you just have them in a non-weight bearing for X amount of weeks, and then you start them off with some physical therapy, or what is that? What does that actually look like in your hands, just briefly?
Yeah, so I think, and I like how you put in briefly there, that I'll try and be as brief as I can, knowing that we only have an hour and I could talk for 5.
Right.
But so an osteochondritis dissecans can, by and large, 80, probably even more, 80, 90% of patients with an OCD, again, those patients who have an open growth plate, they will do well with relative rest. Remember, cartilage only survives by motion, and so you don't want to immobilize them completely. And so you get them to do ankle pumps. You just limit the amount of mechanical or compressive loading through that to allow the bone to heal. And as the growth plate is open, they have the potential to do so. And that can be 6 to 12 weeks of relative rest. In other words, no contact sports. They can walk on it, but judiciously and within the confines of their symptoms. And I try not to put people into cam boots. So that's the osteochondritis dissecans. And so for the purposes of residents looking on this, if somebody has an open growth plate, you don't rush those to surgery. Most of those will do well. For the other probably 90% of patients who present with traumatic injuries, a little bit of that is dependent on what you see on MRI or even X-ray or CT scan, where if it's a stable lesion, in other words, if there is still if the bone is still intact to a certain degree, those patients may benefit from an injection of a biologic to augment the bony healing and to try and produce a physiological grout in the space, in the small space, particularly if it's less than 10 millimeters, and if there's no large volumetric cystic problems. And again, it's relative rest. So walking within the confines of the symptoms, don't put them into cam boots. You'll just ruin their proprioception. But again, it's functional limitation really in terms of I don't want them going over in their ankles, so no sporting activities. They can wear functional bracing and so forth, but I don't want them in cam boots typically. Now that may not be on the boards because I think people do like to put them into cam boots, but for me that's a little bit cruel and unusual punishment and deconditions the entire limb. So for those people, if they are symptomatically better at 6, 8, 10, 12 weeks, then they most likely avoided a surgical intervention. You follow those carefully with X-ray or CT or MRI even. MRI lags behind real time in terms of the presence of edema. Even in a treated OCL, we'll see edema. It's relatively normal up to 18 to 24 months afterwards. But certainly CT scan, you should see some infill into the lesion. In those that fail that, then we have to divide surgical intervention into sort of 2 broad categories, and it's either reparative or replacement strategies. So you have this, okay, so operative treatment, bone marrow stimulation, retrograde drilling, osteochondral autograft, and allograft. So we'll talk about bone marrow stimulation first of all. Chuck Pai Wong in Boston many years ago looked at lesion size of a predictor of outcome. And he was onto something at that time because probably 12 years ago, only about 20% of papers reported on the size of the lesion. And of course, now we know the size of the lesion is the greatest single predictor of outcome. So it was difficult for anyone to predict how people were going to do if they didn't report accurately what was going on. And in fact, in the follow-up, only about 25% of papers at that time were looking at MRIs or CT or any sophisticated imaging. So we really didn't have good data. Chuck Pai Wong came along then and said 15 millimeters was a critical size beyond which microfracture, which there's a bone marrow stimulation used at the time, would fail. Subsequently, Laura Ramponi from Rizzoli, who worked with us, and the ICCRA reported that figure is probably now 10 millimeters. So that's the standard across the world. 10 millimeters is used. At anything less than that, we try and repair with bone marrow stimulation. That's where we use a burr. Occasionally we'll use an awl, but we won't microfracture in the traditional Stedman way by creating problems within subchondral plate. So what we want to do there is we want to create a vascular supply to the defect, and mesenchymal stem cells locally will migrate to that point, and then they'll start to differentiate into collagen type 2. The big problem with microfracture, as it was in those days, is that when you microfracture, and this is some really nice work done by Dexter Sun and Dr. Ariana Giannakis have both shown this. When you microfracture the subchondral plate, you actually destroy the plate. So think of the subchondral plate as the rafters on a roof, and the tiles are the cartilage. So if you come along and you take half those rafters away, and then you put on the most elegant tiles onto the roof, after a while, mechanically loading that roof, it'll just collapse because there's not enough subchondral plate. And that's what microfracture does. It destroys the subchondral plate. There's very few absolutes in orthopedics, but it will never return to normal. So we now know, both in the ankle and in the knee, that microfracture really isn't the best thing to do. We still want to get the effect of those differentiated cells in the area. So we just do an abrasion plasty almost of the subchondral plate until you get a blush, and you can see that in a non-tourniquet ankle. You'll see that there's just a slight blush under the subchondral plate. Now we know that a blood supply will get into the area. We haven't destroyed the plate, and that's where we'll use an adjunct then, either a biocartilage or, and that's a trade name for that Arthrex use, and I have worked with Arthrex as a disclosure. Others, Zimmer, use de novo, which is a particulate cartilage allograft. And so you can put those in as an adjunct to your bone marrow stimulation, with or without concentrated bone marrow aspirate or PRP. So just to go, to divide these into two silos, there's the reparative osteochondral lesions, which are those which are less than 10 millimeters. That's where we do bone marrow stimulation, not microfracture, using the same principles that Stedman and Shapiro and Glimcher have talked about, where you're recruiting local stem cells to the area to differentiate into type 2 collagen. And that can be helped with a scaffold and helped with a biologic like PRP or concentrated bone marrow aspirate. And then if you think about lesions that are larger than 10 millimeters, well, those lesions, simply again, getting back to the rafter analogy, that if you have a large volumetric size defect and there's virtually no rafters left in that, and then you come along and you put in, you microfracture it, well, the whole thing will just collapse. It'll be of no value. So Pierce Granton showed that many years ago, that a large volumetric size defect should be treated not with reparative strategies, but more replacement strategies. And so at the time, he took an osteochondral plug from the lateral femoral condyle of the knee, the ipsilateral knee, and then he transplanted that into the talus. And it did very, very well. Now, of course, this was, again, a trade name of Oates. And so what he was doing was transplanting, well, we get back to this osteochondral unit. So he was transplanting cartilage, the osteochondral, or sorry, the chondral plate itself and the subchondral bone. So therefore, the likelihood of success of this was very, very high. And indeed, if you look at the data for an Oates graft, by comparison to microfracture, Oates is over 90% of patients do well typically. And because you're not trying to regenerate or repair anything, it's really the cartilage is there, and there's no surgeon in the world that can really replicate normal cartilage. By contrast, in any reparative tissue, by very nature of the name, we're trying to repair something, and we just never do. Again, getting back to Fred Shapiro and Mel Glimcher's work back in the 80s, where they showed that when you do microfracture something, or with any bone marrow stimulation, you get type 2 collagen, which is great. But the problem is that de-differentiates over about 12 months into type 1 collagen, which just doesn't have normal mechanical properties. And again, Hayo Thurman in Germany has shown that 100% of these at 5 years, 100% will have started to fibrillate and degenerate. So microfracture or bone marrow stimulation at 10-year survival is probably about 70%, 75%, where some nice work done by our current research fellow, James Butler is showing that with oats, it's again, it's sort of high 80s at 10-year survival. So it's slightly better than bone marrow stimulation. And the only reason is, again, it's you're not making cartilage. You're not trying to make cartilage. You're just transplanting normal cartilage.
Right. And so you mentioned, we kind of have it into our two large groups, the reparative and then kind of the replacement therapy. We talked about bone marrow stimulation and how that's really not really up to 15, but really up to 10 millimeters in diameter. And anything that has like a, large volumetric lesions would probably be better served with, some type of an Oates procedure where you're actually replacing it with the cartilage, subchondral plate, and the bone as well, like kind of a bone plug. And you mentioned earlier doing it from the same side, or getting it from the same knee on a non-weight bearing portion of the knee, and transferring it down. It has good outcomes, good benefits, over 90%. Now we always see and hear about retrograde drilling. Should we be when is the time to use that? Should we be doing retrograde drilling and scoping, any of these lesions? Are there any indications to do that? And after that, I want to kind of dive a little bit more into the biologics that you have mentioned a couple times.
Yeah, so it's a great question. We did a lot more of this retrograde drilling than we do now. Many years ago, Rick Ferkel popularized it over in SCOE in California, Masato Takao in Takao University also. And it's probably best reserved now for osteochondritis dissecans in those cases where there is an intact cartilage cap and you just have a defect in bone underneath. And you can come very nicely. Rick has shown a very nice, elegant paper where he uses an ACL drill guide to come through the sinus tarsi, retrograde drill into the defect, and then you can put in your biologic du jour. Typically, he'll use, I think, iliac crest graft. He'll pack that in there, and it heals that bone in very nicely. The big problem is when we're using different appetites, we use calcium phosphate at one point, and we injected that in. And all you need is a tiny crack in the cartilage, and it ends up in the joint, which is not a good look if you're doing this arthroscopically. So we abandoned that. And so, yeah, I think we don't do an awful lot of it now. As I said, it's really reserved just for osteochondritis dissecans or for a large cystic or bone void that has an intact cartilage cap, intact not just on MRI, but actually on arthroscopy. It's the link between arthroscopy and MRI is not always sensitivity and specificity is not 100%. Doug Mintz years ago showed a corollary between the MRI, particularly with T2 mapping, was almost, in his paper, was almost an equivalence of scope. We haven't found that. We published our results, which were slightly different, to show that really MRI both over and underestimated truly the cartilage quality. It could determine the quantity, but not really the quality. So you could have little microfissuring in there that wasn't a harbinger of a good outcome. So we now know, as you've been, I think, one of the first fellows ever to do in-office nano-arthroscopy, where we have the ability to confirm what we believe will be there on MRI, and we can do a small scope with a 2 millimeter scope in the office to look at the cartilage before we make a determination. And that's, under local. The patient doesn't need any general anesthetic. It's very, very quick. You can just have a look at the cartilage. And most importantly, the patient gets to look at it themselves, and we can probe the cartilage to see if there's any fibrillation, if it's blottable, or whether it's fractured or fissured.
Oh yeah, I remember my first one. I thought I thought it was interesting. Both, we're looking at it, the patient's looking at it as well, and so we're all kind of getting real live feedback. They're talking around their phone, so it's definitely fun and interesting. I really enjoyed it. I'll probably do it in my practice. And so that's retrograde drilling. You talked about oats. And so one of the things that you mentioned here and there throughout this talk is kind of augmenting with, PRP or some of these different biologics. Can you kind of just give us an overview of some of these different biologics and kind of maybe about how they work, and then when do you use them?
Right. One of the big problems with biologics is there's a lot of people who believe in them because they've looked at the science and they know the science, and they know the lane in which it's best reserved to use these biologics. And then there's a massive industry out there. There's 400 regenerative centers in New York alone, and pretty much 90% of these have no scientific oversight. So PRP, which you quite rightly put down here, contains all these growth factors, cytokines, and so on and so forth, and it's drawn from blood. So it's a very easy thing to draw and very easy to centrifuge it out. It's far more difficult to quantify what's in there, and it's far more difficult also to come up with good quality data to show that it actually works. So it's been used for everything, vampire facelifts to hair regrowth to all sorts of things. But in the orthopedic realm, there is some good quality evidence, level of evidence and good quality data to show that it is useful. Maidan and others have shown that when you use just an injection of PRP as a biological adjunct versus HA in a patient who's had previous bone marrow stimulation versus control, the patients who have PRP have better quality and quantity of cartilage downstream. So we know what PRP does. It works not just at the local level, it works also in the joint as a system. So we think of PRP affecting the synovium. It upregulates hyaluronan. It downregulates the metalloproteinases responsible for the catabolic effect. So it's a very potent anti-inflammatory. It's also a very potent chondroprotective agent. And in small areas, it certainly can produce a chondrogenic response. But I think what we have to be really, really careful of is in a patient who comes in with grade 3 or grade 4 arthritic change, and injecting the old magic crystal PRP in there, it's not going to give them a new ankle. It's just, right. And that's the problem. So there's so many people out there who are, and I have to be careful what I say on a podcast, but I think what we call is back of the brochure scientists. It's people who sort of read the information, and tell their patients that this is going to cure everything. And of course it doesn't. It's part of the program. It will be helpful, but we have to know the lane in which it best works. And I think for us, we use PRP, which is predominantly, as I say, mostly an anti-inflammatory, chondroprotective in that role. And for small lesions, we'll use that to try and promote some chondrogenic infill. By contrast, then, when we use concentrated bone marrow aspirate, and I presume that's your next slide. There we go.
Oh, yeah.
Perfect. We haven't set this up. Just let your audience know this is not a setup here.
No.
But anyway, the big difference, I always am asked, what's the difference between PRP and concentrated bone marrow aspirate? BMAC is a trade name, so we have to try and keep away from that. So, but CBMA is what we use. And so we take that typically from the iliac crest. We take about 60 cc's, we spin it down, and we get about 4 to 5 cc's of, again, very similar to PRP insofar as there's lots of growth factors and so forth. But there's also a relatively small population of stem cells, which is probably less than 1% or less than, in many cases, less than 0.5%. And a very powerful anti-inflammatory interleukin receptor antagonist protein, or IRAP. And IRAP is really the body's own steroids. So when we use CBMA in both patients who've had reparative surgeries or bone marrow stimulation versus those that have not been treated with CBMA plus or versus just microfracture or bone marrow stimulation alone, you can see that PRP really does improve the quality and quantity of regenerative, and I'm going to say chondroregeneration in there. I don't know if it's really true cartilage, but it needs sort of neochondrogenesis. But nonetheless, T2 mapping, which is, is this sort of color stratification of cartilage. When we looked at studies, and there's Charlie Hannon, again, one of our previous fellows, looked at this, and he showed that was improved, particularly in the superficial layer, and that was a harbinger for improved long-term outcomes, both in bone marrow stimulation. And then when we use concentrated bone marrow aspirate in the Oates grafts, we found again, Chris Morosky, again, one of our previous fellows, and Keir Ross and others have shown that when we do that, we reduce the amount of subchondral cysts that we often find. Many of these cysts are asymptomatic, but nonetheless, they're radiologically present. And when we use CBMA, we reduce the presence of those cysts by about 20 or 30%, which is significant. The other thing to remember when you're doing an oats graft is that about 20% of the cells on the periphery, where you take that graft out and there's a hole, they'll go through apoptosis and die. So when you put in CBMA, it's almost like a physiological glue in there. It will it really seal that host graft interface fairly quickly. And again, that's why we use it. So I think for us, because you can take marrow aspirate in an office, but it's not the most pleasant thing for a patient. So we'll use PRP in an office setting, and if we're in an operating room, we'll use preferentially the concentrated bone marrow aspirate because it has the addition of the stem cells, albeit in very small quantities, and it has, most importantly, this IRAP or interleukin receptor antagonist protein, which PRP does not.
Perfect. That was a great explanation, and you actually summarized what I was about to summarize. So I'm glad you beat me to it because you said it way more elegant than I probably would have
Oh,
said
I don't
it.
think so. No, I'm just reading your notes here, Cody.
And so, we have these CBMA that you just talked about for use alongside with oats. Because of the IRAP, and you also talked about PRP going along with some of the bone marrow stimulation. Now, what about these different other scaffolds that we hear about? What are those, and do those have any roles in treating these lesions?
Yeah, I think they do. And a lot of good work has been done in NYU by Eric Strauss and others to look at this in the knee. Because many insurance companies still regard them as experimental, even though ACI, we've been in this country since Tom Minus brought it in from Sweden in '94. They still regard it as experimental. So we find it difficult to get in the ankle to get this covered. So, but in Europe, they use it probably more than they use oats grafts. And there's some nice studies to show there's an equivalence, particularly a 10-year survival. The Rizzoli Institute with Sandro Giannini and Laura Ramponi and others have shown that there's an equivalence between what we see. And again, they've used T2 mapping as their outcomes in an MRI with oats versus ACI and AMIC, where they use these porcine collagen 1,3 scaffolds, and then they use the cells on top of those. So I think there is, this is an area that we don't have enough information in the United States to be conclusive. Rick Ferkel did a nice study probably 10 years ago using AMIC and published on that. And again, that was an equivalence to oats. So I do think there's a role for this. We just don't have the experience right now in the ankle world in this country on it.
Right. And this is AC that, just like you mentioned, where we go and there's two different ones. One where you have the 2-stage, where first stage you go and you get the chondrocytes, then you put it on the matrix like you were talking about, and the other one, which is just a 1-stage AC. And so I guess so you just kind of answered it. Right now, we don't necessarily know or have the necessary indications for when you'd use one versus the other, I guess you'd per se in the ankle or in the talus.
Yeah, as you quite rightly say, the initial the Karolinska Institute published on this, but in the early 80s, and where it was a 2-stage procedure, and it wasn't until the 1994, I think, that the FDA approved it in this country. So ACI was a 2-step procedure. So we would take cells back then it was from the knee, and we'd send them off to Genzyme in Boston. We'd culture them. They come back 3 weeks later, and then we'd implant them and use a periosteal flap to cover over that area. But of course, periosteum is composed, the cambial layer and the fibrous layer. And if you put when you take it off, and you could quite easily put it in back to front, and of course now you're starting to grow bone through endochondral ossification. So it wasn't particularly loved by everybody. Tom Minus, as I said, in Boston, was a wizard at it, and he produced some very elegant and work on this. But then it became because it was a two-stage procedure, it took a long time. It was very difficult to get it through the insurance process in this country. So it really was for select centers. Whereas then AMIC and Macy came in, and they were using different type of collagen scaffolds, and they became a one-stage procedure where you could actually grow these cells on the scaffold. There's an Macy implant where it's put in, and you cut that out. It's a collagen 1. It's usually porcine graft, and you cut it out to the size of the lesion and then put it in. But it has to be remembered always that regardless of what we put in as cartilage, or as a cartilage analog or mimetic, ultimately, no matter what we put in there, will fail unless we put in a mechanical structure to support it. So whether you use any of these grafts, you really have to be careful that if there's a bony defect, you have to fill that. In the ankle, we're lucky enough, we have a reasonable supply in the calcaneus. We can take calcaneal bone graft and we pack that in, and you really have to pack it in to try to create a structural graft in there, and then you can place your cartilage graft on that. Because if you don't do that, and one of the things that we learned very early on in the Zimmer de novo experiment. De novo is particulated juvenile cartilage, which has cells as well as a scaffold. And in the early stages of using de novo, many doctors were putting that in to the defect ab initio, that the entire thing was filled with de novo. But of course, that was a setup for failure, where you're putting in these cells into a bony defect and hoping that they will turn into bone and subchondral plate and cartilage. Of course, that didn't happen. And de novo got a relatively poor reputation because it was used, again, outside the lane in which it was designed. It probably works better than the outcome results in the literature would indicate, in which it shows that it's no better than microfracture alone. And in those patients, or in those surgeons who are using it carefully, I think Lou Schoen is one of those who has used de novo very judiciously and very carefully, where he does pack in a bone graft and then he puts de novo on top of that, and his outcomes have been terrific doing that. So regardless of whether you're using AC, Macy, or AMIC, or de novo, biocartilage, whatever it is, remember the name. It's an osteochondral injury. Osteo has to be addressed just as much as the chondral aspect of it.
Yeah, I think that's a great point that you just made, that a lot of people, or at least a lot of learners, sometimes won't think about it or forget, even when they're doing questions. So I think even these topics have shown up on questions and on board exams now. So those that are listening, if they show you a CT scan, they show you a huge, large defect, don't click Macy. Maybe they may be better served with some type of an allograft or an autograft of some sort. And is there ever any situations where you're just doing a combination of these? You're doing scaffolds, CBMA, PRP, just a combination of things. Is that any role for that in treating these osteochondral lesions?
Yeah, I think there is. And I think for me, again, it's sort of going back to one of your original questions. Why did you come to America? Well, it's because we have the ability here to keep pushing the envelope. And Walter Bone, who was one of my mentors back at HSS many years ago, used to tell me that, look, if you're doing the same operation that I'm teaching you to do today in 20 years' time, you're doing the wrong operation, because there's no such thing as 100%. And if you're trying to close the gap, you need to get better. And the only way to get better is to be innovative and start thinking outside the box. So that's why, for me, and I hammer this into the residents all the time, in orthopedics, it comes down to two components predominantly. There's a mechanical component and a biological component, and you need both to be successful in your surgical outcomes. So in the absence of poor biology, in the presence of poor biology, which is often the case in the talus, because, of course, cartilage is avascular, its inability to heal itself in a synovial environment, we've got to try and put in a better biological environment. So the answer to your question is absolutely. When I do bone marrow stimulation, I will always use concentrated bone marrow aspirate. I will tend to use an acellular graft, mixing it with bone marrows, which is the patient's cells themselves. So the biocartilage is a is a trade name for acellular matrix, or sorry, an acellular matrix. And then we add in the concentrated bone marrow aspirate, and it makes a paste. It looks like garlic powder. You know, when we've been operating together, we mix this on the back table, and it looks just like, you know, salt or garlic powder. Then we mix it, and then we're able to put that in to the cartilage defect, again, when it's small, less than a centimeter, and then we put fibrin glue on top of it. Now, Dan Grande, who is the current president of ICCRA, will warn us that you can't put in massive blobs of fibrin glue into an area that you have mesenchymal stem cells, because, of course, those stem cells will create this fibrous secretome rather than a chondrogenic secretome and push the cells down a path of differentiation into fibrous tissue rather than into hopefully some form of neocartilage. So for that reason, you see us when we're using this, we're really just using a tiny little drop of fibrin or fibrin glue on top of this to try and seal it, rather than, you know, using that as the scaffold itself. So yeah, so in answer to your question again, yes, for reparative stuff, we're using a scaffold, we're using cells, and then we're using bone graft wherever we need to into the bone itself. So that's sort of a combination of all the things. Similarly, even when we use an oats, as I've said, we know when we use concentrated bone marrow aspirate that that reduces the presence of these subchondral cysts. You know, Victor Valderbano in Switzerland, when he was doing the oats graft, he told us using SPECT CT scan, he saw, you know, there was 70% of patients had these large cysts, and we just didn't believe him. And of course, nothing ruins belief in yourself like follow-up. And then we started looking at our own studies, and we were at 65%, so no better than Victor's study. And even though patients weren't symptomatic from that, or most of them weren't, we still were worried. You know, why do we have these large cysts at the interface? And so we started to use concentrated bone marrow aspirate, and I think it's a process of creeping substitution, that it equilibrated that, and say that with a few pints of Guinness on you, but I think it equilibrated that process of creeping substitution at the host graft interface, and so you didn't see that those cysts afterwards. And then occasionally we'll use biocartilage in osteochondral lesions. Again, we use up to a centimeter size dowel that we'll use. And then if there are larger lesions than that, we'll use the kind of the snowman effect, where we'll use multiple grafts stacked on each other. And even after that, if there's still some cartilage defect, which is relatively small, we'll use biocartilage, but it has to be a very small amount. We don't use it all the time. So yeah, we use combinations of these all the time. And I think anytime you talk about cartilage, you have to talk now about biologics. And it's not just at the local level. As I said earlier on, when you inject a biologic into a joint, it doesn't just go to the small defect you're dealing with. It changes the dynamic of that joint as a system. And it does so through interactions through the synovium, upregulating and downregulating, as I said, upregulating hyaluronan through the synovia sites, which downregulates IL-1 and TNF-alpha and so forth. So it has a very dynamic effect on the joint as a whole, and reduces this catabolic milieu that's created by any defect in the cartilage.
John, I think that was just perfectly said. I thought it was a great podcast. I think we went over a ton of material. We talked about how to evaluate these patients. We talked about how they show up. We talked about the imaging and what to look for on different images. We talked about the non-operative treatment option, and we talked about a lot of different operative treatment options. We talked about biologics. Anything else you want the people or the listeners listening to this to know about, osteochondral lesions of the talus before we wrap up here?
No, I think, look, you've said it very eloquently. The only thing I would echo is what I would tell you, as a skillful, thoughtful, and I think that's very important, surgeon as you are, I know that you won't be doing what I'm doing in 10 years. You're way too smart for that. And you're going to come up and you're going to teach others, to do the same thing. Keep on asking questions. Why are we doing what we're doing? And how can we improve? and then we'll keep closing that gap. And so I want to thank you for an opportunity to appear on your podcast. It's very, very humbling to be here, and I appreciate it very much.
Well, again, thank you so much for being a guest on the podcast. Those listening, go in and follow Dr. Kennedy on social media. We'll put all of his social media links in the description, as well as go leave a review. Let us know how much you enjoyed this episode, and until next time.